Okay, since it's 3 after and it's getting late on the East Coast, we're going to go ahead and get started. I'm on the West Coast, so it's still only 5 p.m. But thanks everyone who's here. I'm sure we'll still have a few folks popping in. Welcome to Shout Your Abortion's Abortion Academy. My name's Erin Jorgensen. I use she, her pronouns, and I'm the communications director at Shout Your Abortion. So today we are having Abortion Pills 101. I'm super excited to get into this. And just a few things before we start. A couple reminders. The chat is not available, but we will have the Q&A is open. So if you have questions, go ahead and put them in the Q&A. And if we have time, we will address them at the end of the session. And there will be a recording available probably sometime next week. So if you miss it or you have to leave, you'll be able to check back in. So our guest today is the amazing Ruchi Kaul. She is a super expert in abortion pills, as you're about to learn. So I'm super excited for this as well. I'm just going to read your bio because it's amazing. So Ruchi Kaul uses she, her pronouns. She's the physician and founder of Maitri Wellness, one of the first direct primary care practices in New Jersey. So if you're in New Jersey, I was creeping on your website and noticed you also do laser facials and stuff too. So yeah, I recommend going if you're on the East Coast. So prior to opening her practice, she taught full spectrum family medicine, including abortion care, to family medicine residents. She was the third U.S. provider, that's the third person in the whole U.S. to start mailing pills during COVID, and contributed to the data that helped the FDA make mailing of the pills legal. So she's a huge part of why a lot of us can get pills in mail. She's a co-founder of the Abortion Freedom Fund and volunteers for the Miscarriage and Abortion Hotline. And she is more recently a co-founder of Abuzz Health. And Abuzz Health mails pills to pregnant people desiring to end their pregnancy, make sure each patient gets the care and resources that they need before, during, and after their abortion. They also want to educate people as much as possible about abortion. We'll put some links in the chat because their FAQ and resource pages are amazing. So they provide resources and information to people, even to people who are not their clients, which includes some of us here. So in her own medical practice, Ruchi integrates Western medicine with older traditions such as Ayurveda and acupuncture, as well as coaching and transgender care, and strives to make that care affordable and accessible. So she's an amazing person. I'm going to go ahead and turn it over to you.
Hi, thanks. Beautiful intro. Yeah, no, I just do this because it's super interesting to me, important to me. And I feel like every time I ask myself the question of whether I want to keep doing this, the answer is like a duh. Yeah, absolutely. So here we go. I put together a little talk for you guys. That is not what I thought I was sharing. I'm gonna find it in just a second. Sorry. Too many. There we go. All right, now I think I can see what you can see. Yes. Make this out of my face. Okay. So medication abortion, what is it? Where did it come from? Why do we have it? Why do people not know very much about it? We're going to get into all of that. And please put any questions that you have in the Q&A, because I want it to be, although I know from this view, I can't quite see it, but whatever, they'll be there. But I want to know what you guys want to know, because there's way more than that, than just what's in this presentation. This is just what is interesting to me and what I hope is interesting to you. But I'm happy to talk about other things as well. Okay, so here we go. Oh my gosh, why is this so hard for me? Okay, all right. What is the abortion pill? Okay, so the reason I made the slide the way that I did is because people say, isn't there just an abortion pill? There's just one pill that I can take. And for whatever reason, I think there is part of the reason, but there's people just think that it's one pill that they take and then it's done, and this is like a magical thing that makes everything go away. That's not how the world works, right? And it actually is, there are many different protocols. There's many different ways that we can terminate a pregnancy. The one that is most commonly used in the US currently is mifepristone and misoprostol. So mifepristone is what most people call the abortion pill. The brand name for that was Mifeprex, and misoprostol is the second piece of the regimen that we use. There are ways. Mifepristone has become easier and more easier to access over the last several years. But before that, when people couldn't just access mifepristone, or even now when people can't just access mifepristone, there is a misoprostol-only regimen that you can use. A lot of abortion providers in the US are not that we're not interested in using misoprostol, but it is harder on the pregnant person to do a misoprostol-only regimen than it is to do a mifepristone regimen. And I know that I can speak for myself and providers that I work with, that we do not want people to go through a more difficult process just because they can't afford it. And so we have found funding, but also most abortion providers, I think, are self-funding. Even though big clinics, right, they're taking what people can pay, and they're helping people to get medications in a way that is the most, quote, most effective, but also the easiest for the pregnant person. People also have used herbs to induce an abortion. And that is definitely something that's more and more talked about now, more recently, as abortion is more just talked about in the press. But we're going to talk a little bit about what that entails and what the intricacies. I don't know the actual intricacies of the details of it, but why sort of people are showing up the way that they are in that space. I'm just going to go to, and I'm going to go into more details about all of these things later, but this is just my quick overview. Okay, mifepristone. So mifepristone is, again, what most people call the abortion pill. This is a pill that studies were done in the 90s. And as you know, I've been reading articles just in prep for this seminar. People were like, wow, this is amazing. This actually works really well. And actually it's really safe. And actually this may be an option, right? So it was approved by the FDA in September of 2000 as Mifeprex, which is a brand name drug. You may or may not be aware that patents on drugs last for 20 years. But it also depends on when they get that patent as opposed to when the drug goes on the market. So something like Nexium, which is not an abortion medication, but it is a medication that people use for ulcers and for reflux. Nexium people got, I don't actually remember the company, but they got a patent for it. And then it went on the market about 3 years later. So 17 years later, they could start selling the generic. The generic is just the same exact thing as the brand name, but when people do a patent, they basically get a monopoly on this medication for 20 years. So they can charge whatever they want because nobody else is there and on the market. And so once the generics are approved, as in not a brand name, but just the actual medication, so there's medicine in there, and there's also binders in the pill, right? And so different companies have different binders or different colors of the pill or different stamps on the pill, and all of that, it all has to go through a process. So the original Mifeprex was approved in September of 2000. The cost was $90 per 200 milligram pill. And at the time, the protocol was to use 3 pills for abortion. So people were taking 600 milligrams of mifepristone because those were the original studies. And so abortion, right there, the cost was actually quite high. It was developed under the research name RU486, and I don't know, I think it's funny. I don't know that anybody like pays attention to this and or notices the punniness of it, but are you 486? Like, are you 486ing this pregnancy? Ha ha ha. Some people still call it that, which I think is really interesting. OBs often will call it that more in terms of the research name. So the generic, we see this, the brand name was approved in September 2000. The generic was approved in 2016. And when I was in residency, I graduated in 2012. So we were already, I guess we were still using the brand name at that time. So the costs were higher, but we were already at that time using just the one 200 milligram pill, which is the current protocol instead of the old one. They would come in packs of 3, and you would use one at a time. The way that mifepristone works is it blocks your progesterone receptor. So your body needs progesterone in order to continue a pregnancy. Your body, if you are AFAB, right? If you're assigned female at birth. So you have periods, like literally we have periods, but those periods of time in which we have our periods, your hormone levels are going up and down, up and down. And so it's not dangerous to have low progesterone levels or high progesterone levels. We have that fluctuate throughout the month. So when it's blocking those progesterone receptors, those progesterone receptors are what allow the pregnancy to continue. That makes that not happen. But then the pregnancy still sits there in the uterus. Okay. And that's why you need another medication. Otherwise, if you use just mifepristone alone, which we do not recommend, it is about 60% effective. But the risk of just mifepristone alone is that the not 60% people, there is a risk of heavy bleeding and hemorrhage to the point of like you're in the hospital and possibly dying, right? So we don't want that. We want there to be a manageable amount of bleeding, a manageable amount of side effects, and this combination of mifepristone and misoprostol is what makes that regimen be 99% effective, but also safe to use on your own. So currently, because there's generics, the cost of the pill is $42.50. And even when I started mailing pills, it was $50 a pill. And then slowly in the last 3 years, it's come down to this much. And, this is one of the biggest driving forces for what the cost of mailing pills are. When you're talking about the cost of going into a clinic, there's all these other costs. There's overhead costs. How many people have they hired to answer the phones or talk to the people or clean the rooms, or how many providers are on staff, and how much time is each provider taking with each patient, and things go up from there. But those of us who are mailing pills, we definitely we know that pregnant people are smart. They know what it feels like when they're pregnant. They know what it feels like when they're not pregnant. They know this is a normal amount of bleeding for me. This is more than I usually have. This is less than I usually have. And when I was in training, we would do this regimen, and we would send people, and we would tell them that they would have to, they would take the first pill in the clinic, and we'd watch them, because I don't know, there's some magic that all of a sudden your abortion provider watches you swallow the pill. So that makes it work much better, whatever. But that second part still had to be done at home. And that was actually the real part that needs to be managed, right? And so we'd give people instructions. They would do this part at home. They would get our cell phone numbers. They would be able to text with us, but they would come back in a week. They would come back in a week, and we would say, do you still feel pregnant? How much bleeding did you have? That sort of a thing. And then we would do a quick exam to make sure, on a bimanual exam, which is one hand in the vagina and one hand on your belly and squeeze, because that's real fun, to make sure that the uterus had returned to its non-pregnant state. And most of the time it was slightly smaller, but not completely gone down to its non-pregnant state. And we know that is a thing, that it takes about 4 weeks for all people to get all of the products of conception out of their uterus once using the pills. So the misoprostol is also not a new medication. It's an old medication. It was developed in 1973. It is currently, and it was at that time, and it is still currently approved for use in preventing stomach ulcers. So people take it. It makes you not make as much stomach acid. It's a great thing. It has been used forever. I mean, I don't know that it was used in 77. I was born in 77 and maybe it was used at that time. But like when I was in training in the 2000s, early 2000s, it was used routinely to induce labor. So people ask how safe it is. It is safe enough to put right next to a about to be born baby's head, right on the cervix to dilate the cervix and start contractions. It is also routinely used off-label to prevent postpartum hemorrhage. I have questions, right? I have big questions about like, why is it approved for stomach ulcers, but not approved for these pregnancy related conditions but people are there. We know how safe it is. We know it is so safe that in a culture where we don't even like do studies on pregnant women and because of ethical reasons and stuff, we know it is so safe that you can put it right into a pregnant woman's vagina and it will induce labor. You will deliver a live, healthy baby if you are using this medication at full term. And it will prevent hemorrhage. So using it, usually what's happening is after somebody's had a baby, they're bleeding a whole heck of a lot. But now where do you put this medicine? Because you can't put it in the vagina because they're bleeding a whole heck of a lot. You actually put it in rectally, and it very quickly helps the uterus contract and make the hemorrhage stop. We're going to talk a little bit about how that works. But the medicine behind it is a prostaglandin analog. Prostaglandins are also present in the head of sperm. And so when you have sex and there's sperm, the sperm actually, one of the jobs it has is it helps open that cervix so that sperm can swim up into the uterus. So in the same way, it is softening the cervix to help open it up. And it also stimulates contraction. So causing the uterus to contract to push out the products of conception. I'm just going to stop for a second. I don't see any questions, but I don't know if that's because I am sharing. So I'm going to keep going. There we go. All right, contraindications. Oh, there I see. No questions yet. Perfect. Thank you. Contraindications. There's a list of contraindications that people use. And I have a couple here in parentheses. So if you're allergic to mifepristone, you shouldn't take mifepristone. There are people who are allergic to either mifepristone or misoprostol, and they're like, I don't care. I really want to do this. I have this anyway. I have a little bit itching. I have a little bit of swelling, whatever. I take the Benadryl. I'm going to take this anyway. In general, that is a conversation to be had between your provider and you when you are a patient, in terms of what sort of risk tolerance is happening right there in that situation. But in general, if you have an allergy to a medication, you probably shouldn't take that medication, right? So allergy to misoprostol, just the other medication, allergy to prostaglandins, which is what the misoprostol is an analog of, and we don't want you having reactions to it. Porphyrias are disorders of the blood that can cause crisis and pain, and there's different kinds. There's inherited ones and there's acquired ones, and the problem is only with inherited ones. It's complicated. If you don't have porphyrias, you don't worry about it. Ectopic pregnancy. This can be called a contraindication. And so when I was working originally with 8-Access, we were like, and when I was training in the way beginning, you cannot use this medication with ectopic pregnancy. That is why we need people to come into the office, is what we were told. People need to come into the office so that we can confirm that they don't have an ectopic pregnancy. So that means that we need to make sure that we've done an exam and we don't feel anything in the tubes. For some people, that means that they won't give the medication before 6 weeks because you can't see anything on ultrasound before 6 weeks, or you don't feel on your exam an enlargement of the uterus until about 6 weeks, and you may be able to feel it in the tube at that time. So some people don't even start offering abortions until 6 weeks because they want to know where the pregnancy is. And if they don't know, they can't be the ones managing your pregnancy. What we found when we were mailing pills in the beginning is that the rate of ectopic pregnancy that we were seeing was a lot less. So there's a sort of question that it is possible, not studied, not enough data, but it is possible that in the early stages, maybe this does work on ectopic pregnancies. But again, we don't have that data. The biggest risk to taking these medications when you have an ectopic pregnancy is not that something is going to go horribly wrong, but it is that you're going to take the medications, possibly have some bleeding, because you could, even with an ectopic pregnancy, take mifepristone and have some bleeding, and then think you are no longer pregnant, and that ectopic pregnancy, it may not have affected. And so that ectopic pregnancy continues, and then ectopic pregnancies can be a fatal risk to a pregnant woman. And so the risk is really that you don't realize that you have an ongoing pregnancy in a place that is dangerous for you. We who mail pills are no longer making people, like, we can't make people prove, right, that they don't have an ectopic. We can't tell every single person to go and get an ultrasound and prove, because then we're going to do the same thing. That means we cannot give pills to anybody over 6 weeks because they have to have gotten an ultrasound. Somebody has to have access to that. Somebody has to have access to a ride to be able to go get an ultrasound, blah, 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 blah. So no, we do give the pills. We tell people, hey, this is not going to work if your pregnancy is ectopic. But we allow people to make their own choices about, some people are like, I cannot wait 2 weeks. I cannot wait a week. I cannot wait a day. I just need this right now. And if it doesn't work, I'll deal with it. And for the most part, it does work. So we don't use that as a barrier. Hemorrhagic disorders, people, so I left ectopic pregnancy not in parentheses because it is an important one to say, like, hey, it doesn't work for an ectopic pregnancy, but if you can't prove that you don't have too many negatives in one sentence, if you can't prove that you don't have an ectopic pregnancy, we're not going to not give you pills. More negatives in the same sentence. How many can you put in one sentence? Okay. Hemorrhagic disorders. When only men were in charge of medicine, right? It was like, oh my gosh, hemorrhagic disorders, that's a bad thing. And then you give a pill that makes a woman bleed. Can you imagine what would happen if a woman bled? That would be so bad, right? And so we can't give this pill to women who have hemorrhagic or bleeding disorders because that would be terrible. Except most women who want, most pregnant people who have a hemorrhagic disorder have had periods in their life and they didn't die from having a period, and they know how to manage their period. And the earlier the pregnancy is, the less bleeding that they're going to have. So usually what we do is we ask people if they have a bleeding disorder, what is that bleeding disorder? What are their periods like? And if they're like, my periods are awful and there's so much bleeding and it's just too much and I need to figure out a way to not have periods anymore, we would then counsel and say, you might want to do a procedure because you would have the same, if not more, bleeding. And again, putting that choice back in the hands of the pregnant person. But it's not really an absolute contraindication. If they say, you know what, my periods are fine, they're normal, they're not like anything different from what I think anyone else has, we say that's fine. And we just tell those people they may want to have a low threshold for going to seek help if they feel like the bleeding is getting to be too much. The cool thing about the misoprostol, though, is the misoprostol helps to stop and slow down the bleeding. And so you can use that to manage that. And then IUD in place was another one that when we were mailing pills in the way beginning, it was like, well, if you have an IUD, we shouldn't give you pills. But number one, if you got pregnant with an IUD in place, most likely that IUD doesn't work anymore. And again, giving that barrier. And again, let me back up for a second and say, when we started mailing pills, it was COVID. People couldn't come in. People couldn't go anywhere to get help. but they were still pregnant and still needed help. And so putting in that barrier of you have to go into an office and somebody has to take out that IUD before it can send you pills, or you have to do it in person so that that person can take out your IUD and then give you pills, is a huge barrier. And what happens when you have a period is your uterus squeezes out what's in there and pushes out the IUD. Is that a terrible thing? No, because it probably wasn't working in the first place. It wasn't either in the right place or it wasn't, properly in the right place because you were able to get pregnant. So what we mostly see though is that people who have an IUD in place and use the pills do just fine. And if the IUD doesn't come out during the procedure meaning the medication abortion, then we tell them to go and get it out and get a new one placed because this one is not working. Okay. All right. Next. So I just think that the uterus is so cool. I also am not the best, let's see, PowerPoint slide person. So I'm sorry that this picture is a little cut off, but I actually took out the bottom part because I didn't think you needed to see it. The uterus is super cool. The uterus has arteries called spiral arteries. They look like the coils of a mattress. This is a 2D picture, so maybe not the best picture. Non-pregnant, pregnant here you see, and non-gravid means not pregnant. You can see how the arteries and the veins are so much bigger and thicker in a pregnant person. And this is in the first few weeks after getting pregnant, your blood volume increases by 50%. It's a lot of percent. And so a lot of it is here, right? It's coming here. It's your body wants to get all that oxygen as much as possible to this new being that you're growing. So as your uterus expands and gets bigger, these arteries also expand and get bigger, and that coil sort of uncoils. And so the flow of blood is stronger. And when you give misoprostol, we do misoprostol vaginally or under your tongue or in your cheek. But if you put it in vaginally, this is actually your cervix right here. So you'd put in pills into the vagina, and it would cause the uterus to contract. And when that muscle of the uterus is contracting, it is pushing down on those arteries. And so it is slowing down the blood flow. It is a super cool mechanism, I think, for how this whole thing works. But when people are worried about having too much bleeding when they're pregnant, it is because these arteries are so big and they're so stretched out. And as soon as we can get them to get the uterus to clamp down on itself, you actually push out the products of conception that are in the uterus, but also slow down the bleeding at the same time. And this is how, after like a postpartum hemorrhage or something, the same thing, you put the medicine in that area, it helps the uterus clamp down and it slows down your bleeding and saves the no longer pregnant person's life. All right. What are the protocols? How do we use these medications? There's so many ways. Let me count them. I don't think I can count them. There are so many. So mifepristone and misoprostol, the ones that we use, it says 1 + 4. So that's 1 mifepristone and 4 misoprostol. And usually we use that for under 9 weeks. What does that mean? That means that you would get the pills in the mail, in your mailbox, venture out to the mailbox, open it. There'll be a little box in it, and the box has 1 mifepristone pill in it. You take that pill, and now from the time that you've taken that pill, you have to take the next medication in 24 to 48 hours. When I was in training, we used to tell people 6 to 72 hours. And some data showed that really that sweet spot was right around 36 hours. And the best numbers were 24 to 48. People will often call and ask like, okay, so should I take it at 24 or should I take it at 48? Like, which one is better? And one of the best things about medication abortion is it is so patient-centered. It is for the person to use in the best way that works for them. So if you're like, I have small children, they need to be asleep, then wait till they go to sleep, put them to bed, and then do your thing. If you're like, I need to wait till my day off, then you take your mifepristone in such a way that your misoprostol doses will fall on your day off, and it works the best for you. There is play in it, and the data is that it's just as good between those 24 to 48 hours. Right now, people are, getting pills from all sorts of sources. And they're like, can I just take this all at once? Because they're worried about legal risk. They're worried about what if somebody finds me with these pills, and what if somebody finds out? And so taking it all at once seems to quell a lot of people's anxiety. There are people encouraging it, but that also sort of encourages the panic. And for now, we are still encouraging people to wait the 24 to 48 hours before you take the next dose. So when you're under 9 weeks, you do 1 mifepristone, and then 24 to 48 hours later, you take 4 misoprostol. You put them either in your cheek, under your tongue, or in the vagina. I personally like to always recommend in the vagina, because if it's possible, like if they're not having heavy bleeding, because there's a lot fewer side effects. And this is a little bit about what we'll talk about in a little while, but that one of the reasons for the mifepristone plus misoprostol regimen instead of the misoprostol only is that there is a lot fewer side effects. It is easier to manage. So when you use it vaginally, there's a lot less nausea, vomiting, and diarrhea. And the less nausea, vomiting, and diarrhea we all have, the better off we all are. So we just do it that way. And there's less. It doesn't mean there's none. Some people still have nausea and vomiting and diarrhea. But also, if you have put pills under your tongue or in your cheek, and then you throw up, then there's real concern about, like, did I get enough medicine? Versus if it's still there vaginally and you've thrown up or whatever, there's less of that concern. So under 9 weeks, 1 + 4. 9 to 12 weeks, 1 + 4 + 4. What does that mean? It means 1 mifepristone, wait 24 to 48 hours, do 4 misoprostol, and then wait 4 hours and do 4 more misoprostol. And at this point, you may have to be putting it under your tongue or in your cheek, because you may be having heavy bleeding with clots. But again, this second dose helps to make sure that the uterus has enough cramping and contractions to push out what's in there and clamp down so that the bleeding slows down. And then interestingly, as you get farther along in pregnancy, the cervix needs less and less of misoprostol to sort of open up and soften. And so when you're over 13 weeks, we do 1 mifepristone, and you do 2 misoprostol, and then 3 hours later you do another 2, and then you basically keep doing 2 until you expel the pregnancy. We don't in this country generally recommend doing anything over 13 weeks. We by medication abortion, there's a whole ISO immunization thing that is basically you have your blood type is like A positive, A negative, B positive, B negative, O positive, O negative, right? Or AB positive, AB negative. The A and the B part and the O part don't really matter in terms of all of this, but the negative positive part, if you are Rh negative, but the fetal blood is Rh positive, you can actually have a reaction that doesn't cause problems now, but it causes problems. It causes problems in your subsequent pregnancies. It can make you have trouble getting pregnant in the future. So in that sense, you'll need a RhoGAM shot, you'll need other stuff. And we have talked about, like, that's just harder and there's more risks. And so we've kind of so far agreed to stop at 13 weeks. If it were easy to get a RhoGAM shot, if it was an easy thing in our culture to say, like, hey, this is readily available, go get it, we may actually say, hey, this is something we're willing to do, but with our legal landscape right now, it's not so much. The question about the misoprostol is, what is the dose? 200 micrograms is the dose. So it is the 1+4 is 200 milligrams of mifepristone is the one, and the 4 is 800 micrograms of misoprostol. So there's that. And then the misoprostol only regimen. So if you cannot get your hands on any mifepristone, misoprostol is quite cheap. And you could do a 4 and then wait 4 hours and do another 4 and then wait 4 hours and do another 4. But with each dose of this 4, so 800 micrograms of misoprostol, the nausea and vomiting and diarrhea can be pretty severe for some people. And then plus the nausea and vomiting of pregnancy itself added to it. Some people really just struggle with it. Even with the second dose, sometimes people are like, do I really have to take another dose? So the reason that we offer the mifepristone and misoprostol over the misoprostol is just because it is so hard to go through that. If somebody wants to go through that, we're still happy to help them do that. And then the herbs to induce an abortion. I just wanted to touch on that. Again, I don't know a whole lot about stuff, but we were talking a little bit before about people. There was a time when we talk about Salem and witches and all that stuff, and we talk about people, and even way before that in England and Scotland and Celtic times, people would do something like a sage tea, right, to have once a month to make sure they got their period. There's a number of herbs in the Western world, but there's also a number of herbs in the Eastern world, and these are different sets of herbs, but people have used them over centuries to induce an abortion. But what herbalists and midwives are saying right now that we're hearing is that requires a lot of sort of tweaking to that is each person is different, and each person may respond differently to different herbs, and the mifepristone seems to be the most effective. And so some people are actually doing a combination of mifepristone and herbs, or misoprostol and herbs, which is super interesting. Again, I am not the expert on that, and I can't give you a lot of information on that's out there, but it is out there, and there are people talking about it. So definitely, if you're interested in that, look into that more. All right. When can you safely use these medications? If you use the pills vaginally, I'm going to flip back and forth regarding taking the meso vaginally. Isn't that the only way an SMA can be differentiated from a miscarriage? If the patient, yes, seeks medical assistance in states where they might be criminalized, that the meso cannot be detected if you take it early. Okay, so the meso can't be detected no matter how you take it. So what I like to tell people is, if you're going to put it in your mouth, that's fine. And then when you're done after 30 minutes, spit it out and flush, right? Then people are worried about like, oh, somebody will see it, whatever, flush it down the toilet. But like when you swallow it, then you're more likely to throw it up. And right, the one thing that we do caution people is that if you do need to go into the hospital or to seek medical care, and people find misoprostol pills in the vagina, they might be like, oh, did you do this? Did you take these pills? Which can actually be solved relatively easily by squatting before you go, doing a finger sweep and finding anything. You can find pills a week later there. There's the vagina is an interesting place, and we can store all sorts of stuff in there. But yes, if somebody is so worried that, what if I have to go to the hospital, and what if they're going to do an exam? Yes, it is good for people to know. And you might notice that as a theme in my talk here, that like, it's not about us making decisions for people and saying this is what you should do. It is giving as much information as possible and allowing pregnant people to make that choice. So to know that if pills are seen on a vaginal exam, this may be something that people will be able to detect. If that makes a difference for you, that is a thing you should take into account. If you use the pills vaginally and then need to go to the hospital because of some rare complication, is there more chance that the hospital would know you use the medication? Blah, blah, blah. Again, same question, I think. My screen is not bright all of a sudden. Okay. So when can you safely use these medications? Originally, the FDA approved them up to 7 weeks in the year 2000. I graduated from residency in 2012. We were already doing them up to 10 weeks. And again, I think I said this earlier, the 10 weeks was even like 10 and 5, 10 and 6 is still 10 weeks. We were doing it because we knew that it was safe. We knew that people were doing fine. Currently, we're using through 13 weeks in the US. Different services are offering it up to different dates depending on their own comfort level. But there are a number of us using it through 13 weeks. In other countries that have like an accompaniment model, which means that they're not necessarily seeing a doctor or an abortion provider, like not a midwife or a nurse practitioner, they are seeing somebody who is not a medical professional, but they have helped other people through this before, and they can bring the person pills. People use them through the second trimester. The problem with that is that then and so a trimester is approximately 13-ish weeks. And so through the second trimester is like through 26 weeks. But as you can see, that's overlapping with viability. And so you are going to deliver a fetus that is breathing. It may not breathe for long. It could be minutes. It could be hours. But then there's all the logistics of having to dispose of that fetus, of legality, et cetera, and just the emotional trauma of being able to do that. In 2020, when we started mailing pills, the anxiety about not being able to access abortion was through the roof, and people didn't really have a lot of knowledge. Like I would be like, hey, you guys, there's a pill. And people would be like, yeah, but the morning after pill only works for like 72 hours. And I was like, no, there is an abortion pill. And people who are very educated, have lots of knowledge, were like, I've never heard of this thing before, right? And so, where was I going with that? But anyways, had a second of mom brain there. But people, you can still use these medications, but you have to think about like what's happening on the other end. You're going to deliver, and when you're delivering in that first trimester, I'm going to call it delivering, when you're terminating that first trimester, there's nothing viable there. It's you expel the products of conception and then it's over. But there's a gray zone where we have to be able to emotionally be able to handle like what is coming out, what we can see. So in 2020, people were freaking out, like, how is this going to work? And how, and didn't really know anything about the pill. And now through things like Reddit and Oars and all these websites and Plan C pills and so many different resources, people have put a lot of information out there, and people are supporting each other. And there's a lot more knowledge about medication abortion, about the pills, about self-managed abortion, about how we can do this, about how to get them, right? And so as a people, I think we have emotionally evolved quite a bit in the last 3 years. And hopefully we'll continue to evolve to a point where maybe people are able to do all this accompaniment model through the second trimester. It really depends on our politics, really. It's not about the safety as much. And then what happens when you use them past these dates? I asked this question because I actually have had 2 patients use them past these dates. The interesting or not, but the part where people get really worried about offering pills by mail is that people say, like, how do you know how pregnant they are? And we often say, like, we trust our patients. We trust people to tell us that this is how far along they are. And most people are telling us the truth, and we're not going to not serve people because a few people are going to try to do something different. But the best we can do is give them as much information as possible. So when you use these past these days, if you guys remember in the way beginning, when I said misoprostol is used off-label for induction of labor. So if you use this and the fetus is viable, you can use the mifepristone part, right? It stops the pregnancy from continuing, but that doesn't mean it stops a heartbeat. It doesn't stop a heartbeat, right? It stops the pregnancy from continuing. At 12 weeks, at 13 weeks, you need the uterus and that environment for that heartbeat to continue, right? And if you're not in the uterus, it is no longer possible for life to continue. When you are 31 weeks or 24 weeks or 25 weeks and you use these medications, it can stop the pregnancy, but still deliver a live fetus. And that has happened. So we are careful to tell people, like, this is a reason we don't recommend using them past these dates, because then you have to deal with what is it, what the sort of the consequences of, like, now you have a live fetus. And sometimes it's a small baby, and that has happened. So knowing what you're doing and why you're doing it and how you're doing it is super important. And then really, how safe are they? The NIH describes that Tylenol overdoses account for 56,000 ER visits every year, 2,600 hospitalizations every year, and 500 deaths per year in the United States. And I'm going to answer your question about efficacy, shelf life, in just a second. It's a good question. So Tylenol is purported to be safe, but Tylenol is processed through our livers and can really give our livers a really hard time, clearly, from all these ER visits. People ask me, like, what would happen if I took too much mifepristone? And I tell people, so again, mifepristone stops progesterone receptors, right? It blocks progesterone receptors. So, like, people will say, like, what if my baby gets a hold of this medication? What would happen to your baby? Nothing, because there's no progesterone happening in your baby, male or female. It's not happening, right? What if somebody swallowed an entire bottle, not that it comes in a bottle, but if it were to come in a bottle of mifepristone and they were to swallow an entire bottle, nothing would happen. Your progesterone receptors would stop working for a couple of days, stop accepting progesterone, and that would be fine. If you were a person who had regular cycles and periods, it would throw off your cycle and your period for a little while, but it doesn't do all this crazy stuff of sending people to the ER and all that stuff. But what a misoprostol overdose do? Again, it would cause a lot of cramping and a lot of discomfort and a lot of bleeding, and maybe not a lot of bleeding if there's not that much stuff in the uterus in the first place. But again, misoprostol is approved for ulcers in the stomach, and so people do give it out freely, and nobody's overdosing on it. It's like I said, it causes nausea, vomiting, diarrhea. People are like, do I really have to take another dose? So we always say these are safer than Tylenol, these medications. Okay, the shelf life of Miffy and Miso. We do, some of us do pills for advanced, for use in the future. So usually what we tell people is that you can keep the medication in a dry, dark place for 2 to 3 years. So it was a large study that showed that many drugs retain efficacy 40 years after their expiration dates, which is crazy. Yes, medication abortion was not on it. I remember antibiotics were on it, all sorts of medications that we were like, we should probably not do this. What I think is interesting, because both my parents are doctors, is that all the doctors know that expiration dates are fake. They're not a thing. It is a rule that the FDA made that says that every medication has to have an expiration date on it. And so the drug companies are like, sweet, we'll put an expiration date on it. In fact, we'll put one that's pretty soon, so that when you see that this drug is expired, you're going to throw it out and get more. And all the doctors are like, yeah, that's not a thing. Just hold on to your medication. It'll be fine. Misoprostol, though, there's like a handful of drugs for which this is not true. And misoprostol is one of those drugs that it does not have the longest shelf life. And so mifepristone most likely probably is good for 10 years, 15 years, 20 years. Again, there's not data on it. But the misoprostol, I think, has been proven to be probably like more like 1 year or less. But the best part about that is it is very easily accessible. Mifepristone is not as easily accessible, but misoprostol is, and I can write a prescription to the pharmacy and anybody can pick it up. But you can keep those pills for 2 to 3 years. And if you're not having bleeding, somebody can call in more misoprostol. Usually when we give people pills for use in the future, we say, please reach out to us before you use the medication, so that we know that you're doing this, and that that you have quick communication with us, so that we can help you if you need. Is that all the things? Let's see. All right. And then why isn't medication abortion as talked about? I know I've kind of sprinkled it throughout the talk, but there is a hierarchy, right, of abortion. There's like and I guess I'm brown, so I can say the things, but like a procedure was seen definitely by white male doctors as superior, right? Because they could be sure that they got out all the tissue and all that stuff. But when I was in residency, what I noticed was that people of color often opted for medication abortion versus white people opted for procedures. And I think that does stem from a lot of mistrust of medical providers. When you don't feel that you are seen or advocated for, it's easier to say, I'm going to do this alone at home. But there's also that extra like piece of women putting themselves in the hands of male doctors to say, like, you tell me what I need. Whereas now I think we have a much better culture of like, I can take care of myself and I don't need you to like make sure that this is done. I can do this on my own. What we saw with medication abortion is we were asking patients what their symptoms were to decide whether they had a successful abortion or not. Well, we don't have to bring them into the office to do that. We can have a conversation. When I was in residency, both procedures were charged at the same rate so that they were not making the choice biased, because Medicaid does not cover abortion. Federal funds can't cover abortions. So we were charging in 2012, 2011, $375 for a procedure and $375 for the pill. I think now people are seeing that that has actually continued. So now people in clinics will charge the same amount for pills as they're charging for a procedure. And I think that's really just a shame, because there's so much less access instead of more access. I think that medication abortion, this is me personally, my own thoughts, takes control away from an abortion provider, because a person will say, like, how do I know that they don't have an ectopic? How do I know that it worked? How do I know? And I think for me, what's most important is that the person who's taking the pills knows, and the person who's taking the pills can get the support that they need when they want. And, you know, not talking about medication abortion and not telling people how safe it is perpetuating an environment of fear and mistrust. And then my last page, what can you do, which is sort of answering that last question. So definitely get the word out. Like, SMA is so safe. It is so safe. And for us in our country, and it's not just like with the politics that's happening right now, but it's also the history over so many years of how, you know, the women's rights movement and all this stuff, and the reproductive justice movement, how people were afraid to take up space and afraid to say, like, this is something that I can do on my own. No, instead it was, the doctor has to make sure that I can do it. Even the stupid thing about, you can't get your birth control pills until you get your pap smear. That is ridiculous, right? And that is what we call holding your birth control hostage. Because if I ever said that I'm not going to give you your blood pressure medications until you get a mammogram, and then you had a stroke, I would get sued. But people do this all the time with not giving people birth control pills, and then saying, well, you didn't get a pap smear, so I didn't give you birth control. And then guess who had an unintended pregnancy? Not the physician who was withholding the medication, right? And so getting the word out about, like, what the real deal is. Like, medication abortion is safe. People should be able to get birth control in any way or form they want to, whether that's abortion, whether that's oral contraceptives, whether that's rings or shots or whatever. People, where can you get it? You go to plancpills.org, and they have a catalog of all the different places that you can get different kinds of pills, whether that's clinically supported teleabortion, and that means that getting pills through somebody like me, where we kind of walk you through the process with as much or as little support as you want. So there's some people who are like, they get a handout and they're like, this is the best abortion process I've ever had. And we're like, okay, but we don't really do anything besides send you pills and give you information. But for them, that is what they needed. And other people are like, how do I know I'm having bleeding? I'm not having bleeding. I'm nauseous. What if it didn't work? And we provide that support to those people. So that's clinically supported teleabortion. And then getting pills, there's a whole bunch of websites where people can just get pills and they don't get all that other support. And if they know that they don't need it, that's totally fine. But there's some people, what's the difference in looking and making sure that someone who wants support is not just getting pills and getting dumped when they need the support. And then clearing misconceptions around the safety versus the politics of medication abortion. I think I've sprinkled that through the talk. I'm going to stop sharing the screen so I can see some of more of the questions. One of the goals I'm working on is pressuring the FDA to approve. Yes. So this is our thing. This is what we really, really, really want, is for Miffy to be over the counter. And what we know is that right now there is a huge gap that we need to bridge. And that is starting from 2020, when people are like, what the fuck is a medication abortion? I just needed to terminate this pregnancy, to now where people are talking about SMA and they're starting to understand what is going on. But there's still a big gap in education. And so what we are doing is trying to bridge that gap and provide not only pills and support, but in doing so, provide education. Because what happens is then, as an entire community, we all learn more and we all learn how it works. And there has been a huge improvement, I should say, in, like, I did abortion starting in I did my first abortion in probably 2005 or 2006. But it's really since 2020, from between 2020 and now, that I've seen a huge jump in like community knowledge about how all of this stuff works. And the more that we can get the word out there, the more likely we are to be able to say this is over the counter. Right now, what we're doing is basically, there's so many providers out there and they're basically just being like, we have pills available, right? We're not flooding the market, but we're kind of like giving a huge option to be able to get the pills. And when there's a huge option, then the FDA sort of is obliged to follow, because if they don't give approval and it's not out there, then how are people going to get it? And so some of us were actually mailing it before there was an approval to mail it, right? There was a COVID thing that was like, there's all these restrictions, so you can mail it. And then it was like, no, now you can't mail it. And we were like, meh, sorry, but like, pills are out of that bottle. So instead of cats out of the bag, haha, my joke. But like, you can't really go back, right? We know it's safe. So why are we going to go back to a place where we're restricting access? Given its safety profile, no, I do not see any medical reason why we should not pursue this avenue. We should absolutely pursue this avenue, and we should all be pursuing this avenue. Obviously, still important. Well, and great to have questions. Yeah. Yeah. So I talked a whole heck of a lot.
Thank you so much, Ruchi. That was amazing. And I'm an anatomy nerd, so I loved so much of that, especially the slide with the uterus and your description of exactly how the pills work. We actually had a couple of questions, we're at actually 9:01. So maybe I'll just ask you one question before we go. You talked a little bit about ectopic pregnancy and contraindications with the pills. So could you tell us what signs someone would look for in the case of an ectopic pregnancy?
Yeah, I mean, we generally, so there's a uterus. So this is how I usually do it. If I'm a uterus, these are tubes and here are some ovaries, right? And you kind of like hang out like this. An ectopic pregnancy is a pregnancy in the tube, right? And so you would have pain that's localized to that's kind of like right above your groin area. For some people, it is a dull pain that sort of gets worse and worse and worse. But for some people, they don't have any pain at all. And the first thing that happens is that the pregnancy rips that tube open and there's a lot of blood flow again, especially going up along that tube, and it rips open the artery and you have a hemorrhage and then you die. So there's not really a a reliable thing, but if people are starting to have pain on one side more than the other, because usually in the very beginning of pregnancy, most uteruses sit a little bit on the right side because your rectum is sitting on the left side. There's only so much space you've got in there, right? And then as the pregnancy advances, it kind of comes more to the center. But most people in the very beginning of their pregnancy, they will have stuff on the right side. But the cramp, that's different cramping, which we can go into, but we're not going to go into. But people generally have cramping because, like I said, the blood volume increases by 50% in the beginning of pregnancy. And so your uterus cramping is your body being like, if you don't give me more liquid, I cannot support this pregnancy and I'm going to push it out. So people do have a lot of cramping in the beginning, and if you want to keep that pregnancy, we say drink a lot of water. And if you're still having cramping, you're not drinking enough water, right? So again, it's not reliable. Like I said, some people have that localized pain that becomes worse and worse on the one side. Some people don't have it at all. You can ask another question.
Thank you so much.
Yeah.
Sure. Okay. So you also mentioned that some people may be allergic to Miffy or miso. If someone has never had an abortion and they wouldn't know that, what are some of the signs that they should look for? So what are potential allergic reactions to the medication?
Sort of just what you'd have with any other medication, whether it's like your lip swelling or itching in your body. Some people have like a scratching in their throat, a rash, anything like that. And if that comes up, I definitely to get like to either, depending, right? Like if it's like a more skin thing, using Benadryl or something like that. But sort of even a similar reaction to some people that they have with like bee stings, or people say I'm allergic to amoxicillin or I'm allergic to Bactrim. Like what happens? There's a whole variety of reactions. Some people have nausea and vomiting, which you wouldn't be able to tell with these because they make you do that anyway, right? But it's just sort of a typical reaction. It could be any of those things. Not a very like definitive answer, but it's different for different people.
Okay. Thank you so much. I don't think that we have any other questions in the Q&A box. So I think that I will close us out. Thank you so much again. This has been absolutely amazing. And there will be a recording available and sent to folks next week. So anyone who registered will get a link with the recording. And when you close out of the Zoom, there'll be a short survey that comes up. If you could just take a couple of minutes and give us some feedback on Abortion Academy, we would so appreciate that. And our next session is going to be on November 30th. So we will see you all then. Thank you so much, Ruchi. And thanks everyone for coming tonight.
Bye.
Bye. Have a good night.
You too.